Hello, I'm Hannah Donnett with the Collaborative on Health and the Environment. Chain enjoys bringing you the latest environmental health science through our partnerships, calls, webinars, science service publications, and social media. I would like to welcome everyone to today's CHE EDC Strategies Partnership webinar, which is titled The Role of Epidemiology and Risk Assessment, a case study of 5 ortho-phthalates. Our moderator today is Jerry Heindel, founder and director of Commonweal's Healthy Environment and Endocrine Disruptor Strategies, or HEEDS. We will leave time following the presentation for a brief Q&A session. You may type in questions through the Q&A feature available on the menu bar at the top of your window at any point during the presentation. After the presentation, our moderator will read out questions for our speaker to respond to. We'll get to as many comments and questions as we can during the Q&A period. For those who have called in on the phone, we've posted slides to accompany today's webinar on our website. You can download these by going to healthandenvironment.org. Please scroll to the bottom of the page and select today's webinar. On the webinar page is a link to the slides. Everyone on the webinar now is muted with the exception of our moderator and our speaker. This webinar is scheduled to last for 30 minutes and is being recorded for a call and webinar archive. So with that, I'll turn things over to you, Jerry.
Okay, thank you very much, and welcome everyone to our webinar today. We're very pleased to have as our speaker today, Dr. Maricel Maffini. Maricel has had a very interesting career. She started out in academics at Tufts University and then went to the Pew Charitable Trust and then later moved to the Natural Resources Defense Council. And she's currently an independent consultant based in Maryland. She's well known in the field of carcinogenesis, reproductive biology, and endocrine disruption, having spent over 25 years in those areas. For the past 11 years, her work is focused on the safety of chemicals in food and food packaging, its regulation, and the market's influence. She co-authored a very important petition requesting the Food and Drug Administration to revoke the use of phthalates in contact with food. She's a very busy person, and in addition to her consulting work, she's a member of the Food Packaging Forum Advisory Board, a science advisor to the Breast Cancer Prevention Partner, and a fellow of the Collegium Ramazzini. So Maricel, thanks for taking the time to speak to us today, and I turn the webinar over to you.
Thank you, Jerry. Thank you very much to the Collaborative also for the invitation. It's a pleasure to be here. I will going to talk today about a publication we had at the end of last year, 2021, and it's a case study on 5 ortho-phthalates, mostly focusing on epidemiological data that is available to us and how that can be used for risk assessment. So very briefly, this is the paper that we published in Environmental Health, and is open access, so anybody can download it. So these are my colleagues from which them I worked for several years on this project. And Xenia Groth used to be with the Food Packaging Forum. Now she is a principal researcher at the Swiss Federal Institute of Aquatic Science and Technology. Jane Monke and Birgit Guke are from the Food Packaging Forum, and Bethany Carney-Malmroth from the University of Gothenburg. So together we worked for several years on this project, and the conclusion of it is this paper that I'm going to share with you today. So as I said, the project started a few years ago, and it was titled Hazardous Chemicals in Plastic Packaging. And you can visit the Food Packaging Forum, and I put the link underneath, and you can read more about this project. But very briefly, what we did in this project, we compiled a database of chemicals that are associated with plastic packaging. There was an overview of the plastic packaging and their hazards, not only which chemicals are allowed to be in plastic materials, but also their hazard characteristics. The database is really big, and we identified 906 chemicals likely associated with plastic packaging, And based on their hazard characteristics regarding human health, we identified 63 of them that rank the highest on human health hazards. We further prioritize these chemicals using a simple, relatively simple criteria. For instance, where they're present in human body, there was data on biomonitoring, for instance. What was the regulatory status under the European REACH law, especially if they were already characterized as substances of very high concern, and also if they had endocrine disrupting properties. So through all those, this prioritization system, we came up with 5 chemicals, that all of which happen to be ortho-phthalates. And in this particular case, the phthalates are benzyl-butyl phthalate, or BBP, dibutyl, diazobutyl phthalate, diethyl hexyl phthalate, the most known of all of them, DEHP. I'm sure all of you have heard of it, and dicyclohexyl phthalate, DCHP. So these are the 5 phthalates that we used to identify if there were any epidemiological evidence of potential human health concerns. So here, so just to start with the most simple question, phthalates are regulated. They have been around for a long, long time, and all these 5 phthalates have a variety of uses, and all the uses are regulated. Some of the uses, the most common use that we are associated phthalates with is as plasticizers, basically adding phthalates to hard plastic like polyvinyl chloride, and making it softer and more pliable. But they are also used as adhesives and lubricants and binders, defoamers, you name it. The number of uses are very large. And they are also used not only on plastics, but also on paper and paperboard materials. We identified 4 different regulatory systems for phthalates, 2 in the European Union through ECHA, the chemical agency, the European Food Safety Authority for uses in food and food packaging, the US EPA, the US FDA, and the US Consumer Protection Safety Commission. So all these regulatory agencies have, some of them have, in the way to regulate chemicals is to identify a safe dose, or a reference dose, as we call it here in this particular publication. So this established so-called safe levels is the amount of each chemical above which the risk to human health increases. They are usually used as a bright line, as if it is above the reference dose is high risk or is unsafe, or is below the reference dose, everything is okay. No risk or very low risk. So this is the way the agencies work with when it comes to chemicals, the identification of reference doses. So we focus on the ECHA reference doses because it was the most updated risk assessment of these phthalates. And on the left-hand side here on the table, we have the reference doses, the so-called safe levels that are identified by ECHA for DEHP, DBP, BBP, and DIBP. The numbers here are in the units of micrograms per kilogram body weight per day. And we also listed here, which is the health endpoint that was used to identify the safe levels. So testicular germ cell depletion and reduced testis weight for DEHP and so on. The great majority, if not all of them, endpoints are related to male reproductive toxicity. So There are currently only 4 RFDs. There are for 4 phthalates. We couldn't identify and reference those for DCHP, the dicyclohexyl phthalate. We only identified a regulatory level that is for uses in children's toys and children's articles by the Consumer Protection Safety Commission, and is a level no more than 0.1% per weight in toys. But other than that, we couldn't find any other reference dose for DCHP. So phthalates, many of you already know, are everywhere because they are not strongly bound to the materials where they are added to, and they come off very easily. So they are part of our daily life, from food to our cars to the dust that is in our houses and personal care products. All of them are related to phthalates, associated with phthalates exposures. So as I said earlier, they have been in commerce and in use for more than 60 years. So we were interested in understanding how these 5 chemicals that have been around for such a long time, what kind of data of human exposures there are, and what levels, if any, health effects have been identified or observed. So the goal of the project was to investigate whether the regulatory safe levels of these 5 phthalates are protective of the public health of other relevant health outcomes in addition to male reproductive development. So we started with a very targeted literature search. This study, I want to make clear from the beginning, this is not a systematic review of the evidence. This was a very targeted literature search. We only wanted to identify studies in humans for exposure to these phthalates. And what we did was just a literature search in different databases. We were using the different names of the phthalates, their synonyms, and then a combination of keywords from metabolites, biomonitoring, children, pregnant women, etc. So then we set out a criteria, which would be a criteria to include these studies. And they have to have the following. The studies must have data on any of the 5 phthalates that we had prioritized. And that data should include the concentration of phthalates, either the parent compound or any metabolite in any bodily fluid. There should be a description of the measured endpoints, and then the association between the endpoint that was measured and the concentration of phthalate should be statistically significant. So what we did with those studies that were included, we identified which was the lowest concentration of phthalate that was statistically significantly associated with an endpoint, and we did a back calculation to estimate the exposure. So this is what we found. Of 64 publications, 38 met the criteria. These were a different kind of studies from cross-sectional, longitudinal, population-wide or small cohorts. All of them only reported on urinary metabolites of the phthalates. DHP, of course, was the most frequently assessed, and we couldn't find any of the studies of these 38 studies, none of them evaluated DCHP. And what we found is that of the 4 phthalates for which we had evidence and we could estimate exposures, we found that DEHP, DBP, BBP, and the IBP were significantly associated with reproductive male and female endpoints, neurodevelopmental, behavior, hormonal, and metabolic endpoints. So this is way beyond the male reproductive toxicity on which the reference doses are established. So when we looked at the at the 10 lowest estimated intakes that were associated with effects, we saw that most of them, if not all of them, were not male reproductive toxicity, and most of them were observed in women and children. When we looked at the studies, you will see here, for instance, the population tested, in some cases were the women, but in some cases were the mothers, and then the endpoint was statistically significant, was measured in the children. So as you can see here, there are a lot of effects that were associated with exposures before birth. Here it's even more striking because what we found is that there is a huge range of intake associated with the health effects that are below the reference doses. Here, for instance, for DHP, there's the dots on each extreme. This is the lowest estimated intake we identify with a decrease in ovarian follicles, all the way to decrease in semen quality. And what is interesting about the EHP in this case is that we found concentration, we found effects that were statistically significant at concentrations above the reference dose. So in all the other cases for DBP, BBP, and the IBP, the effects that we saw were all below the reference doses that are marked with the higher, the bigger dots here, and here. In the case of butylbenzyl phthalate, the effects that we observed were at between 8,000 and 5,000 times lower than the RFD. And for DHP, this one associated with decreased semen quality was 7 times greater than the reference dose. So that was quite interesting. And again, this is a table, just a different way to show the graphic that I just mentioned. Here again, for DBP, the reference dose is 6.7. The lowest estimated intake associated with a statistically significantly associated with a health effect was 0.19, and the highest estimated was 2.86, just to see the bookends of the estimated exposure related to the reference dose. So among the health effects that we observe in children were prenatal exposures included psychomotor or mental development, decreased intellectual memory and executive development. Behavioral changes were also statistically significant with the estimated exposures, increased odds of attention deficit hyperactivity disorder, and also a decrease in masculine behavior in boys. We also identified metabolic health effects, and these were both in children and adults, and were basically in these 3 buckets associated with pancreas functionality, with thyroid function, and with fat tissue accumulation. It was interesting, there are quite a few studies on thyroid function with decrease in the concentration of T3 and T4. When it comes to reproductive health effects, we observed both in females were very interesting, where there were important decreases in the number of fertilized eggs and total eggs that were also of low quality. There are reduced in the number of specific type of follicles in women's ovaries. Puberty was delayed. Again, in males was semen quality, and number of sperm was reduced. as well as male hormones were associated also with a decrease in male hormones associated with the thyroid levels. So all this led us to a few conclusions. There is a lot of what we observe in the epidemiology data, the endpoints that were observed, the health effects that we saw that are not commonly assessed in toxicity studies. So that is an important point that I think deserves a lot of discussion. How we do toxicology to then use those animal studies to identify safe levels. The effects that we saw were at such much lower levels than the safe doses. The human evidence that we identified is quite substantial. Pretty much at the same time our paper came out, there's another paper from the University of Exeter that they also identified a large number of human studies with strong evidence of health concerns. Again, another thing that we should be discussing in terms of how we do regulations of chemicals is the reference doses. They are usually used as bright lines, and they are not bright lines. There is a continuum of risk that is happening, and using a number that is seldom reviewed based on new evidence of human health concerns is not the best way to do risk assessment and risk management. Both the science and the market are dynamic. So the safety evaluations and re-evaluations of chemicals, especially those that have been in commerce for a long time, should also be a dynamic process. And the last one here is that we are missing a conversation. We are not having a clear dialogue between the regulators and the medical community and the academics that produce a lot of the science. What we have here are what we call the bookends of environmental health. On the one hand, we have the regulators that are using, for the most part, animal data, sometimes in vitro data, and they just go for some sort of a checklist to identify which is the safe dose, and that is what it is. And then we have, on the other end, we have health practitioners that are actually seeing people, children, adults with illnesses and ailments that are not necessarily associated with genetic problems, but are more associated with environmental exposures. And there is no real communication between these two very important sectors. So a more fluent dialogue needs to be happening between regulatory agencies and health practitioners, because we are all here in the middle, including the regulators and the health practitioners. We are the people that we should be protected from exposures. So the last message here is that we need a profound modernization of risk assessment process. As I said, a lot of these effects that we observe in humans, in the human studies, are not typically tested or looked at, identified in animal studies, or even in vitro in some cases. Human studies should be taken into account any time that there is a reassessment of a reference dose to identify whether or not the health risks of these chemicals in commerce should be reassessed. So there should be a mechanism of some kind to trigger a potential reassessment of reference doses for chemicals that have been in commerce for a while. And I think that's all. Thank you very much. Happy to take questions now, Jerry.
Great. Now it's time for our Q&A session. You may type in your questions to the Q&A feature available on the menu bar at the top of your window. We'll get to as many comments and questions as we can. Jerry, would you like to read out the first question for us?
Okay, thank you. Well, so I have a first comment, and that comment is, oh my goodness, this is mind-blowing. It's just unbelievable that nobody has done this before, and how the results of the animal studies and the endpoints affected in the animal agree so much with the human studies wherever they can be measured, the same endpoints. That's really, really exciting. I'm kind of confused though, because what I always thought, well, so apparently regulators use animal studies to get the endpoints for the NOELs and LOELs and RFDs and stuff like that. But every time it seems like we talk to regulators, they say, oh, we don't believe in animal studies. We need human studies. Those are the important studies. And now you got human studies here. So by all rights, that should change the whole world of regulatory policy. So you need more than a conversation. So have you had anything more at all? And what do you plan to do to get this more out in the public and the regulators to see this and make some changes?
Well, I understand that they said we need human data, but when you have new chemicals that you are about to regulate, there is no human data if they haven't been in the marketplace, right? So you have to use other means to identify a reference dose, a safe dose. Now, when there are chemicals that have been in the marketplace for a long time, and there is already data on biomonitoring, people are looking at those chemicals, are they staying in the human body, etc. I don't see why not keeping an eye on the human data, on the human information, and start, regularly looking at these studies and see which ones we should start paying more attention to reevaluate what is currently the safe dose. Now, I particularly haven't had any conversations directly yet with regulators to see how it could be used. I know today at this particular time, actually, there is a whole discussion about epidemiology and toxicology in the Tox Forum winter meeting that is happening right now. Today, the session was on epi studies and toxicology. So I hope something comes up. I hope there are health practitioners or not others that bring in the information that they see, and that there is a real conversation between the regulators. I think we cannot continue to think that once we set a level, that level will remain safe forever. That's what I think is more important to change.
Okay, so let's see, here's a bunch of questions here. Do you think we should change the current application of uncertainty factors to animal studies to conduct risk assessment to arrive at the RFD? Does that make sense?
I think different regulatory agencies have different ways of doing applying uncertainty factors. For instance, for FDA commonly uses 100 as an uncertainty factor. It is part of the regulations, but in some other cases they have used, I see, they have used 1,000 as an uncertainty factor. EFSA also, it depends on the amount of information and the quality of the information they have, the size of the uncertainty factors. I think in general, I would prefer to have a systematic reassessment of chemicals rather than using a big uncertainty factor that we never review.
Mhm. So the key thing here in epidemiology studies is exposure assessment. And you didn't say anything about looking at these studies that you were using and determining their quality based on the exposure assessment. There must be some studies that only measured once during pregnancy, and maybe that measurement is not very accurate. Did you look at that at all? And maybe see if one measurement gave the same results as multiple, or anything else to try to figure out the exposure assessment and how real it was in these studies?
We did a quality assessment of the studies. We actually had identified a few more, and there was some information that was missing. So I reached out to the authors. In some cases, they gave me more information, and in some cases they didn't. So when we couldn't identify the information we needed, we couldn't use that study. But there was a consideration of, when we did the kind of a quality assessment of the studies, whether the confounders were identified, the type of description of the exposure assessment they have done. In many cases, the exposure was coming from biomonitoring from NHANES. So we were using those values that were provided by NHANES as well.
So another way to maybe look at this is, instead of just looking at the individual phthalates, since they're usually found in mixtures in people, to look at a mixture did you do that at all? Just look at phthalates in general and lower RFD endpoints?
No, what we did see is that in some of the studies, if not all of them, measured more than one at a time. And some of the studies, they only identified one phthalate that was statistically significant on all the endpoints that they measured. So we only took that information from that study. But the one thing that we know, or we cannot say, is that where the phthalates that we measured, that we use, the studies that we measured, where they come from. Because in biomonitoring studies, they come from all different sources, from your shampoo, if it has it, to the food that we eat. But it would be interesting to look at now across one endpoint, how many of the phthalates were statistically significant, and see if there is some kind of quantifiable reference dose that could be suggested. But I think this is much more complicated than what I'm saying.
So among the studies that showed effects at levels less than the RFD, have you any sufficient data to use a benchmark approach?
I think the conversation has to happen between the epidemiologists that do the studies, how they utilize the data, and the regulators, what they need. I'm not a pro on benchmark doses or modeling or any of those more sophisticated studies.
There's several questions related to food packaging about the concentrations observed in the food separately from the level introduced with the packaging. That could make a difference. There's one example that in Alaska, clams were observed to have 300 to 400 parts per billion collected from the wild. So I'm not sure what the question is there. But.
Just on the food side of things, the phthalates that get into food are most likely coming from manufacturing processing equipment. There's very little, very few cases where the final packaging, what you buy at the store, would have phthalates in it. We still have phthalates in gaskets for like jars and the like, but conveyor belts, lubricants used throughout production facilities and the like, those are most likely the main sources of phthalates in food. Now, FDA doesn't have a migration limit for phthalates in food. It says that a manufacturer can use as much phthalate that is needed for the final material to have the use that they need, the performance they need. So they leave it up to the manufacturer of the material to decide how much phthalate could be there. So we don't really have an assessment, at least in the US, in the food supply of how much and which phthalates are present. The latest the closest thing to that was a study that FDA put out in 2018, where they looked only at PVC-based plastic materials in, as I said, in jar gaskets, in the beer bottle gaskets, and through conveyor belts and tubing used in manufacturing. But they still find like 50% weight on some of those plastics was the EHP. They also found a lot of replacement plasticizers in those materials. So I think there has been a shift in the marketplace towards eliminating these ortho-phthalates.
Okay, two last questions. The first one is, were there sufficient data in any of the studies with impacts far beneath the RFD to look for non-monotonicity?
I couldn't tell that.
Yeah.
From the analysis we did. No.
Okay.
I can't tell that.
So based on the results and the impact and the importance of this study, what's the next chemicals that you're going to do? Do you already have plans to work with this group on another set of data like this? Because it seems like you probably need more than one to convince them being your policymakers and the regulators.
Well, one thing that with another group that I've been collaborating with, we've been trying to put out there the message of regulating chemical classes. And I think this is one example of a chemical family that needs to be regulated as a class. And there is an ongoing effort at the US EPA, Environmental Protection Agency. It is actually now doing risk assessment of, I think it's 5 or 7 phthalates, to which we submitted comments saying that they should be looked at together as a class, not individually.
Yep.
EFSA did that with phthalates. They did an assessment and they grouped them and they identified a reference dose for 4 of them together. So the class of 4 have a unique reference dose rather than having, again, different reference doses for each individual phthalate. I think the more we do about that, looking at classes, the better we will be, because we will be reducing the exposure altogether. I don't have plans for other groups, but I would suggest that whomever wants to do, I think PFAS should be a good candidate class to look at.
All right, thank you very much. This was terrific and eye-opening, and we really appreciate doing that study and the time to explain it to us today. I'll turn it back now to Hannah.
Thank you, Jerry.
Yes, thank you, Jerry, and thank you, Maricel, too, for all of your work on this. We're approaching the end of today's webinar. A video recording will be available on Che's website soon, and tomorrow you'll receive an email containing a link to the video. The next CHE partnership webinar will take place this Thursday, January 27th, and is titled Environmental Health Impacts of Synthetic Turf and Safer Alternatives. To learn more and to RSVP, please visit our website at healthandenvironment.org. If you are new to CHE and would like to stay updated about upcoming events or more, please sign up to receive our newsletter by selecting the Join Us tab at the top of any page on our website at healthandenvironment.org. Additionally, if you appreciate these CHE partnership webinars bringing you the latest environmental health research for free, we encourage you to support CHE's ongoing work by making a tax-deductible donation via our secure website. Again, our website is healthandenvironment.org. With that, I would like to thank our speaker, Dr. Maffini, for taking time to present today, and to you, Jerry, for your excellent moderation. Thank you so much for joining us. Wishing all much health and wellness. Have a great day.